He was a 52-year-old gentleman. He had an acute coronary syndrome in 2015, and he was continuing having exertional angina on medical follow-up. In December 2021, he had an inferior VLMI which was non-thrombolized, and he continued to have class 2 angina and was presented to us in February 2022. ECG showed inferior leads, there were Q waves, and his echo was LV was normal size and ejection fraction normal. So in view of his recent inferior VLMI and continuing angina, we took him for angiogram. So if we see this angiogram, the left system, the left main was normal, LAD was occluded just after giving a big diagonal. LCX was a codominant type of vessel which was having normal with no significant disease. The same findings were confirmed in RAO caudal view and RAO cranial view. The LAD was flush occlusion, having no stump over there, and the distal LAD was not visible from the antegrade flow. When we did its right coronary angiogram, the RCA was having the critical stenosis in the mid part, which was explained as inferior VLMI, and there were good retrograde septal collaterals which were filling LAD. And this LAD filling was, there was a bifurcation at the distal end. This was his LV angiogram, which shows his preserved LV function, and there was anterior wall was moving normal. So if we see the angio summary of this patient, this was a case of LAD CTO with RCA disease. The challenges which we faced were there was an ambiguous stump, there was a big diagonal at the proximal stump. If we see the length of occlusion was more than 20 millimeter, there was bifurcation at the distal cap, which might be a challenge in doing ADR in these cases. It was a good contralateral collateral, so retrograde approach is good, but RCA was diseased, and there was CC2 type of collaterals which were seen. So this was a case of proximal camp ambiguity. So what are the things which we can plan in this case? Either we can do an IVUS guided entry, we can plan the IVUS at the side branch and do a localization of the stump, or we can modify the proximal cap. Either we can move the cap, or we can go with the retrograde part contralateral injections and contralateral collaterals to open the LAD. So if we see the algorithm to open the CTO, if we global CTO, first and foremost, we have to do a dual injection in this case, which we did. We localized the proximal cap, we localized the length. The proximal cap was ambiguous, there was a big side branch. So according to this, we can either do an intravascular ultrasound in these cases. If we are successful, it's good. If we are not going successful, then antegrade wiring could be done, and not possible, then go for a retrograde case in this case. So what is basically IVUS-based antegrade wiring? It is basically done in patients with flush occlusion with a good side branch, and you localize the stump from the side branch while the pullback at the LAD diagonal. So we did this approach. We thought first we will try to go with proximal stump localization, try to do a live guided wiring, and if unsuccessful, we have good retrograde approach with the contralateral collaterals. So we took two arterial axes, 7 French were taken to radial artery by 6x7 slender sheath. We took a 7 French femoral artery axis, hooked it with EBU 3.575 French. First, we thought we would just go diagnostic, so we took a JR6 French for contralateral injection. For doing the pullback, we wired the diagonal, and wired the panel, took the pullback from the diagonal. And if you can see on the IVUS panel, there is disease at the part of the osteo of the diagonal, and at 7 o'clock, we can clearly see a stump coming. So angiographically, we placed our IVUS catheter there. We did localize the stump from there. If you can see both the apicaudal and RAO cranial view, the IVUS catheter is parked there, which shows that LAD stump is present there, and which was confirmed with the live IVUS on the right panel. This was a live IVUS wiring. We took a fine cross micro catheter. It was parked there, and first we thought we can try with Gaia 2 wire in this case. After parking the wire, this was the live IVUS. If you can see on the right side, my Gaia 2 wire is at the 10 o'clock position, 6 o'clock position, trying to penetrate the cap. After repeated attempts, we were not able to penetrate this cap because the cap was very stiff. So we knew that we are able to localize the stump, but still we are not able to penetrate it. So we changed our strategy from Gaia 2 to Conquest Pro. So after this Conquest Pro, you can see in the IVUS wiring, my wire is at first at 9 o'clock. It's coming at 7 o'clock. Now it has localized the stump. It is penetrating the stump, and this penetration, after some manipulation, we were able to penetrate the stump part. And if you can see, the same thing was documented angiographically. My conquest wire, which is running parallel to the diagonal, but I was guided, we are sure that it is inside the LED stump, and then it pierced it. So if just summarizing what the IVAS findings were there, if you can see at the first, the wire was at 11 o'clock. We tried to move counterclockwise, moved at 10, rotated it 8 and 9, localized the stump. We saw the stump, we penetrating the wire in that, put up extra pressure, and the wire entered the CTO segment in the lower panel. So we were sure that we have entered the true channel in the lumen part of the LED, which was then confirmed with your contralateral injections, and we can clearly see that we can easily advance the conquest wire in the distal part of the diagonal branch. So IVAS work was done, IVAS catheter was removed, and my wire was in diagonal 2, so either I have to either rewire it. So we just give a small balloon dilatation in the proximal part, not going till the distal part, and we change the wire of CN to CON over a crusade catheter, over a fine cross catheter. So this then wire was repositioned in the LED, and then it was dilated with 2.512 mm balloon, and this was then implanted on IVAS based measurements of 2.75 28 mm stent was implanted, and then the proximal part was dilated with 312, and IVAS showed a good expansion of the stent. This was the final view, having a good TIMI3 flow, and RCA was then dealt with it. RCA's 338 stent was deployed in the same sitting. So if we're summarizing it, the step of IVAS guided wiring is basically we have to put a floppy wire in the side branch, pull back from the IVAS from the side branch, see the optimal entry, take the stiffer wire on the microcatheter, torque into the right direction, and do an IVAS pullback from the main vessel confirmation for the re-entry. This technique will not be effective whenever there is a calcium at the stump. We won't be able to localize the stump in these cases. So summarizing this case, this was a challenging case of the ambiguous stump, but IVAS helped us in going to true lumen to lumen entry in this case, and by simple IVAS guided entry, we were making it to complex lesion simple. So use of adjunctive devices depends upon the anatomy, and we should always have a plan and strategy and backup strategy if one fails or stalls. Thank you.